Good afternoon, everyone. As we continue on with our discussion of the key terms and concepts used in hospital revenue cycle, this is going to be part two of that discussion. And so I appreciate the conversation and you all attending. So thank you very much for your presence. Again, this is just a disclaimer statement that I say at every presentation, that every effort has been taken by the author of this presentation to ensure that the information shared was as current as possible at the time it was developed and presented. The primary intent of this presentation is to be informational only and to share this information in a manner that is more relatable and understandable to all of us in healthcare with various backgrounds and levels of experience. The information that is shared is only intended and not to take as informational and is not to take precedence over any state, local, and or federal guidelines, organizational policies. This is just how revenue cycle has made sense to me from somebody who came from the clinical side for so many years and just really had to learn from the beginning about revenue cycle in a hospital. And as I will start and have started every single one of these videos is, why are we doing this? Why are we tying in what we document and working collaboratively as a team with coding and finance and providers is because no money, no mission. And if we want a place to carry out the mission of caring for our patients, then we need to work collaboratively. As I had mentioned in the previous video, the relative weight that is assigned to medical severity DRG is a heavy factor in the calculation of the payment to the facility. DRGs really came along in the late 80s, 1980s, and really put conditions that needed that were similar in terms of conditions and resources needed to take care of those conditions into a diagnosis-related group. And that has been assigned a relative weight. The other significant factor is the hospital base rate. That is also unique to each hospital, just like the relative weight is unique to each medical severity DRG. The hospital base rate is comprised of the following factors: the wage index for the area, the labor-related portion, non-labor-related portion, and the geography. There are other methods called outlier payments that can add to the hospital reimbursement, such as DSH, referred to as disproportionate share hospital payment. This was intended for those hospitals that treat a disproportionate share of low-income patients. However, with the Affordable Care Act that is opening up the doors for more access to health care insurance, this outlier payment source will be decreasing. There's also an outlier payment source for teaching hospitals to cover the indirect educational costs of medical education and also the patient care costs related to the teaching of residents and medical students, and also what's becoming more the standard, which is pay for performance, meaning that they are linking payment to a facility based on the quality of care of those patients. So as we discussed about the medical severity diagnosis-related grouping, the most critical aspect of knowing which MSDRG, medical severity diagnosis-related grouping, is having the primary diagnosis being established. The most critical aspect of the assignment of the primary and second diagnoses is the establishment of that primary working diagnosis, that in conjunction with the assignment of the secondary diagnosis encompass the information that is crucial for the selection of the medical severity diagnosis related grouping. The medical severity diagnosis selection, MSDRG, has again a unique relative weight assigned to it. The relative weight is a heavy factor in the calculation of the payment to the facility. It is a measure of the utilization of resources used for that patient in the inpatient admission to an acute care hospital. The higher that relative weight, the higher the payment to the facility. So as we discussed, it's the relative weight in combination with the hospital base rate that is used to calculate the payment to the facility. So again, this just is a slide to illustrate that the relative weight, RW, that is assigned to the MSDRG, the medical severity diagnosis related grouping. Remember, each MSDRG has a unique relative weight assigned to it. So the relative weight times the hospital base weight equals the hospital payment. So, for example, when you're assigned to a DRG of 195, and it's just a number, but it's the way it works in the coding book, there is a geometric length of stay, which is the length of stay that is used really to identify how many days we're going to get paid for a patient's diagnosis, regardless of the amount of resources used to take care of the patient, and regardless of how short of a stay or how long of a stay it is. So that's a geometric GMLOS, geometric length of stay, which is, again, it takes out the outliers of those that stay short amount of time and a long amount of time. It's the length of stay that is used to identify how many days we're going to get paid for a patient with a certain diagnosis. There's an AMLOS that is not used very often. That has the outliers calculated into it, so it is often not used. Now, we are able to see that a relative weight of 0.7028 is assigned to DRG 195. So, again, that DRG of 195 that has a relative weight of 0.70258 times, and I'm just picking this out of the blue, a hospital base rate of $5,443 equals a hospital payment of $3,825.34. Just a reminder, there's a unique relative weight assigned to each MSDRG, and regardless of how many tests are ordered or how long this patient stays in the hospital, we get paid the same amount, regardless of if there was extraordinary amount of resources to care for the patient or not. It's the same dollar amount. So just let me illustrate to you how we have a situation where a coder clarified some documentation on a patient record. So this is a situation where we had a 79-year-old patient who presented to the ED with shortness of breath and was admitted with a diagnosis of community-acquired pneumonia. The vital signs and lab work done in the ED revealed fever, tachypnea, leukocytosis. The chest X-ray showed infiltrates. The sputum culture was positive for Pseudomonas. The patient had a 6-day length of stay. The discharge diagnoses were Pseudomonas pneumonia, lactic acidosis, asthma exacerbation, hypoxemia, chronic bronchitis, and that possible sepsis was documented in the consulting physician's note only. And I took this example from one of my coding resources that I use. So this is an example. So this slide will illustrate to us The difference between a clarification query sent about the sepsis diagnosis that was documented in the consulting doctor provider note only, but was not documented in the attending provider. And so, provider's notes. So therefore, the query was sent to the attending provider about a sepsis diagnosis, and the provider confirmed that the patient had sepsis. So on the right box, you're able to see that with the clarification query, we were able to sequence the code for sepsis unspecified organism in the first position. The resequencing of these codes with sepsis being confirmed with this patient is that the assignment to the medical severity diagnosis related group of 871 led to a reimbursement of $19,682.62 without this clarification query being sent. And there's no clarification as to if the patient had sepsis because it came from the consulting provider's notes. The reimbursement to the facility was $12,916. That's a difference of $6,700. Now, if you multiply that even times 5 patients, that's at least $30,000 difference in the payment. So that's how that's important is that that's more equipment, more money towards services that we can open and provide to care for those patients in the acute care setting. That's how this makes a difference. When we all collaborate and work as a team to really provide the accurate story that leads to the highest specificity of coding, that leads to the assignment of the MSDRG, which increases the payment to the facility. So we have money to carry out the mission. And again, I just want to reiterate a discussion that we had earlier or a point that we discussed earlier. If a provider does not document in their notes a finding that was found in a pathology report or an x-ray report, such as pneumonia, or a cancer diagnosis found in a pathology report, if it's not found in the attending provider's notes, then the coder is going to send a query to the provider to clarify and ensure that diagnosis is meant to be a part of the medical record, because it is the provider the attending provider documentation that is needed for the coder to be able to accurately assign codes. And we really wonder how increased document integrity can really help the provider. Many times I hear, seriously, I have enough to do. True, I know you do. How does that help me get through my day any quicker? Well, when we're documenting accurately and giving the correct picture, we are getting ahead of the queries from coding by documenting the complete and accurate picture from the very beginning in the documentation. Secondly, the increased specificity of the documentation of primary diagnosis and secondary diagnosis leads to the highest specificity of codes, which leads to an increased case mix index, which is documentation of the complexity of the patient that increases the hospital revenue, that in turn allows us to offer more services to our patients. Counseling, education, ventilators, ECMO, the list is endless. We know it is. Once again, no money, no mission. Again, these are some of the references that I used and resources, so hopefully you'll find them helpful also. Once again, I want to thank you as we all walk through this journey together and as we all learn the benefits of revenue cycle to all.